Okay, this is the last of the lectures in the acid-base balance discussion. Uh, we have been looking into this particular topic over a month and in a very detailed way we went. An associated disorder called renal tubular acidosis is a very important condition wherein you, many of the postgraduates and even qualified people, they don't have a very good idea about renal tubular acidosis. Very confusing disorder and confusing pathogenesis and manifestations. So that will follow this very logically because we have discussed acid-base disorders and renal tubular acidosis will be a logical follow-up of that. And then we are going to look at the electrolyte disturbances, like particularly hypernatremia, hyponatremia, and then potassium disorders and other miscellaneous conditions like hypocalcemia, hypomagnesemia, and things like that. So at the end of that, I'm going to do what is called a fluid balance, that is water balance, and that completes the fluid and electrolyte and acid-base disorders as a bunch for a period of 2.5 months. So which will give you a very clear idea about that. And after the completion of the electrolyte and fluid-based disorders, we are going to give you a test which comprises of 20 questions. And these 20 questions will be from acid-base, electrolyte, and fluid disorders. And those have to be physically answered by you. In the demo room, all of you will be made to sit on a convenient day. And Dr. Sudhir Garu is planning to have a physical examination on these topics. So this means that will be scored and that score will be utilized to generate internal assessment. So please be aware that this is not just a time pass you are learning, but of course you will also be scored. Okay. So we are going case-based approach of the mixed acid-based disorders in the presence in context. So this slide is very familiar with for you, wherein you know that the metabolic acidosis, the primary abnormality is pH is down, and so when the pH is down, then the here bicarbonate is down, and then the secondary variable also is down. Likewise, primary where the pH is up in case of metabolic alkalosis, so the bicarbonate is up as well as the PCO2 up. This means opposite side. Respiratory, the acidosis, the pH is down, of course, but the primary variable is up and the secondary variable is also up. They are opposite in direction. pH is low, higher in respiratory alkalosis. PCO2 and bicarbonate are lower. This is called respiratory opposite. We know ROMS. This is very clear. So the fundamental assessment is what is my pH and then what is my bicarbonate and carbon dioxide. Okay. So simple where there is compensation, but there is appropriate. There is compensation attempted, but this is still not adequate to cover. That means there is some other disorder which is not allowing the compensation to be appropriate. So in general, remember, mixed disorders do occur whenever there is metabolic acidosis, alkalosis, respiratory alkalosis combination occurs in acetyl salicylic acid, salicylate poisoning, sepsis, and liver failure. So these are the conditions which are associated with metabolic acidosis, MA with RA, respiratory alkalosis. Okay, metabolic acidosis, respiratory alkalosis combination. Think of acetyl salicylic acid overdose, sepsis, and renal failure. When metabolic alkalosis goes with respiratory acidosis, just the converse of the above, we require to know the COPD with excessive use of diuretics, which is the acid wastage. Okay, so the cause of alkalosis is the diuretics, and the cause of respiratory acidosis is the COPD. Retention of carbon dioxide is due to COPD. The alkalosis is because of excessive use of the diuretic. Then you have a respiratory acidosis and metabolic acidosis combined. So for example, you think of a patient who had cardiac arrest and severe pulmonary edema. So the cardiopulmonary arrest retains the acid that produces respiratory acidosis, that produces lactic acid accumulation, which produces metabolic acidosis. So, and another combination could be AGMA and metabolic alkalosis can be there. There is anion gap metabolic acidosis with metabolic alkalosis. For example, a patient who has got diabetic ketoacidosis has developed severe vomiting. What happens? The DKA produces anion gap metabolic acidosis. The vomiting produces alkalosis. Or people who had renal failure with vomiting, renal failure produces AGMA, vomiting produces metabolic alkalosis, a combination. And finally, you have AGMA plus NAGMA. That is both anion gap and non-anion gap, two types of acidosis are occurring in the same patient. For example, a patient has got a methanol poisoning or ethylene glycol poisoning, and he is also a patient of renal disease, renal failure. Renal failure is renal acidosis, let's say, renal tubular acidosis. So that produces the NAGMA, and the metabolic methanol poisoning produces AGMA, or this patient with methanol poisoning had diarrhea, and that diarrhea can lead to NAGMA. So various combinations are possible. So in general, if the patient has got a metabolic disease like diabetic ketoacidosis or respiratory, liver failure or chronic kidney disease, over and above that he has got something else, a poison that he takes like acetyl salicylic acid or methanol or something, or he had either diarrhea, vomiting associated, or there is a respiratory drive difficulty like COPD, interstitial lung disease, and then respiratory depressants like barbiturates. These scenarios can produce mixed acid-base disorders. Okay. Now, I just gave you the clinical background. Another scenario is you can have an endocrine disorder underlying, wherein the potassium retention is there, sodium washout is there, hypertension is there, hypervolemia is there, or there is a diabetes associated with metabolic acidosis, renal adrenal insufficiency with metabolic acidosis, or as I told you, Cushing's, metabolic alkalosis. Primary aldosterone is a metabolic alkalosis. In general, endocrine disorders are notorious to produce mixed acid-base disorders. So what do we have? Chronic respiratory disorders, metabolic disorders, liver disorders, endocrinopathies, unexplained vomiting, diarrhea, diuretic usage. These can produce a host of combined disorders. In addition to toxins like metabolic acids are added, or acetyl salicylic acid like acids are added, or there could be overdose of theophylline which produces respiratory alkalosis by hyperventilation. Okay. So these rules we have been seeing several times, and I am not going to spend much time on this slide. Now this we have done last time. The first question is what is the pH? And it is strictly 7.4 as far as the blood is concerned. If it is less than 7.4, it is decreased. So we have two possibilities, because if it is decreased, that is acidemia, is there acidosis, either metabolic or respiratory. If it is respiratory, there will be an increase in the, increase in the carbon dioxide because of carbon dioxide retention causing respiratory acidosis, or the carbon dioxide may be decreased in the same way as the primary variable bicarbonate, and that is the metabolic acidosis. When you have alkalemia, immediately look at the pH is higher and then the carbon dioxide is lower, that means they are on the opposite side, so respiratory alkalosis. Carbon dioxide is higher as well as pH is higher, then both are on the same side. We are dealing with metabolic acidosis. So the metabolic alkalosis. So these are the various conditions we understand. And now we also looked at how to work up a patient of acute respiratory acidosis, because it is a very life-threatening condition, intubation, and what is the change for every 10 units of carbon dioxide. We know in acute it is 0.08, in the chronic it is 0.04, and bicarbonate compensation also we know, and for every 10 units of bicarbonate, 10 units change of PCO2, how the bicarbonate changes, that 1, 2, 3, 4 table also we worked out. In case of respiratory alkalosis, where you have the pH is higher and the carbon dioxide is lower, that is respiratory alkalosis. And what are they? Because they are all treatable causes, need further workup. Every 10 units of delta PCO2 departure from the normal 40, 0.08 in acute, 0.04 in chronic. And look at the bicarbonate compensation, how whether the compensation. Now we have the fourfold table. So in the acute, in case here, because there is a drop in acute respiratory acidosis, the PCO2 is up. The secondary variable also will be up. Bicarbonates, that is 1 unit up. In case of chronic, it will be 3 units up. There is more time, so the compensation is more. Whereas when you come to alkalosis, the PCO2 is lower, the carbon dioxide is washed out, and then naturally the bicarbonate also will be lower, 2 units down, and here it is 4 units down. So this 1, 2, 3, 4, you have understood. This also we have looked at, okay? And then we have worked out the bicarbonate compensation for the given PCO2. And if the bicarbonate concentration is lower than expected, so lower than expected, it is definitely because the bicarbonate concentration is lower, it is acidosis and it's metabolic acidosis. The bicarbonate concentration is higher, that is alkali is retained, that is metabolic alkalosis. This also we have looked at. Now, let us understand the two, now go to the acidosis, metabolic and also metabolic alkalosis will be the topics of today. Of course, the mixed disorder scenario. So let us say the first one we will see here is the sodium cation is 140. This is balanced by 105 chloride and 25 bicarbonate, together 130, and the anion gap is 10. That is normal. That is chloride and bicarbonate together, when you subtract from sodium, that is the anion gap, which is around 10 to 12. Okay. In case of non-ion gap acidosis, the sodium is again 140, but the chloride is 124 and bicarbonate is 15, total 139, sorry, 130, 24, 139. Make that as that. 129. So 129 and 11 is the anion gap. So that is the scenario where there is a bicarbonate drop. There is a pH also is lower. It is metabolic acidosis, but there is excess chloride. This is what is called hyperchloremic acidosis. Okay, means what? Whenever the anion gap has not changed, for a drop in the bicarbonate here from 24 to 5, the 19 units, the chloride has compensated for that. There is an increase in the chloride, and nothing happened to the other anions like chloride and bicarbonate together are managing this. The drop in the bicarbonate, there is an increase in the chloride. That is, no acid is added from outside, and the body is managing by increasing the chloride. The hyperchloremic acidosis. Not that hyperchloremia causes acidosis. Hyperchloremia is a manifestation of this acidosis. Because bicarbonate went down, the other variable which matches that, the chloride has increased. How about agma? There is an acid added here. Here the chloride has not changed, it is 100, and then the bicarbonate is 15, 115 total. And from 140, if you subtract it, anion gap is. Here, the difference in the bicarbonate, the lowering here, is not matched by the chloride, but there are other anions added to the blood. That is the extraneous anions like keto acid, like lactic acid, like salicylic acid, like methanol, ethylene glycol, all that mud piles will be here. Means this is normochloremic acidosis. In other words, if you look at the chloride value, you know whether it is hyperchloremic magma or normochloremic agma. That's what exactly is the anion gap. Anion gap is another word saying what is whether the chloride is compensating or some other anion is compensating. That's what exactly we are looking at. The moment you see magma, you have to expect the chloride to be higher. If it is not commensurately higher, there could be an associated agma also. The moment you see agma, we expect the chloride to be normal. If the chloride is higher, it means there is an associated nagma also. Understand? So look at the chloride also, that's important. So let's go now with the discussion of metabolic acidosis, then followed by metabolic alkalosis. Respiratory acidosis and respiratory alkalosis we have completed. So what we do? First of all, when we have metabolic acidosis, what is metabolic acidosis? Metabolic acidosis is a low pH, low bicarbonate, and low PCO2. That is metabolic acidosis. It could be NAGMA, it could be AGMA. The first step would be, of course, to look at the anion gap. So, let us say if the anion gap, then once you know the anion gap, look at the delta anion gap. So, this obtained anion gap minus 12, which is normal anion gap, that gives you the delta gap. If decide if NAGMA or AGMA depending on the delta. If the delta is plus minus 2, then it is NAGMA. If the delta is more than that, then it is AGMA. So we did the first moment. The moment we see a low pH associated with low bicarb and low PCO2, our diagnosis is metabolic acidosis. Primary diagnosis. Is there a combined disorder? That is the question. For that, first of all, what is the anion gap? If the anion gap is rather normal, we are dealing with AGMA. If the anion gap is more, how do we know that? Sodium minus chloride plus bicarbonate, we got an anion gap. And what is delta anion gap? Anion gap that is obtained by calculation above minus the what is normal anion gap is 12, that becomes the delta anion gap. If the delta is more than expected, normal being plus minus 2, then if it is more, it is AGMA. If it is normal, that is within plus minus 2, it is called non-anion gap metabolic acidosis or NAGMA. We know that if it is NAGMA, we require to know the urine anion gap. Okay, we need urine anion gap to decipher whether it is positive or negative. If we are negative, we are dealing with the gut. If it is positive, renal tubular acidosis and the kidney. How do we know the urine anion gap? Urine sodium plus potassium minus chloride. Why did we not consider bicarbonate in the urine? Because urine is usually acidic. Not much of bicarbonate is present in the urine. In other words, so bicarbonate is almost negligible there. So we didn't take into account bicarbonate. But then why did we add potassium here? Potassium can be a significant contribution to the urine, unlike in the plasma where it is 4 units only. So we have to add potassium. Sodium plus potassium minus chloride, normally this should be around 30. If it is positive, then we are dealing with renal tubular acidosis, and if it is no need of any osmotic gap here. Osmotic gap is required only when we are dealing with the AGMA component, not with the NAGMA component. For NAGMA, we require urine anion gap. Okay, urine anion gap is positive, renal causes and renal tubular acidosis. Urine anion gap is negative, GUT, negative, gut, or any, uretrosigmoid anastomosis, pancreatic fistula, and things like that. Now, we want to know whether the compensation is appropriate or not. So, we have to work out whether the bicarbonate is adequate and the carbon dioxide is adequate. Both have to be worked out. The mnemonic for this particular thing, of course, we know either used cars or harder. So you know what they mean, and earlier also I have told you. Uretrosigmoid, and then the all the things. You know all that. Renal tubular acidosis. All those things you have to remember. Then go to the other side. Calculate the anion gap. Of course, I have calculated. If it is more, then if it is AGMA, then do an osmotic gap for the DD. If it is NAGMA, this is the table. You go this side. If it is AGMA, you go for the differential diagnosis. Here the focus is reduction in the bicarbonate. It is not compensated by chloride. There is no hyperchloremic acidosis. It is rather normochloremic acidosis. And then if AGMA, add the delta anion gap to the bicarbonate. Now what we do? We got a delta gap here, and that delta gap we add to the observed bicarbonate. calculate the delta bicarbonate. This is 24 minus bicarbonate. Observe this particular thing is substituted there. This one. So for example, we will take here. Sodium is 140, chloride is 94, bicarbonate is 14. I know the bicarbonate is lower. There is no hyperchloremia. So I am dealing with an anion gap acidosis. Did the anion gap? It is 32. My delta anion gap will be 32 minus normal 20, which is normal 10 or 12, which is equal to 20. This number I have to add to my bicarbonate. My bicarbonate is 14, so I added that 20 to that, so I got 34. We know that 24 is the cutoff value. Here the bicarbonate is much more than what we expect if the compensation were to be normal. Then what happens? If the bicarbonate is higher than the 24, which is the case here, there is an excess alkali from the metabolic side. That is an associated metabolic alkalosis. On the other hand, if you get here less than 24, that means the bicarbonate is rather lower and there is an associated nagma. Because agma already we have counted, there will be an associated nagma. You understand now? Again, I am repeating. Obtain the delta anion gap. In this case, the delta gap is, the anion gap is 32. The delta gap is 32 minus 12 normal, which is equal to 20. So the delta gap of 20, I added to the observed bicarbonate. Why? If there were to be no compensation, this 20 would have been added to be, would be the added to the bicarbonate. If there were to be no anion gap, the bicarbonate would have been 14 plus 20, which is 34. That should be normal. Shouldn't be normal. Normal is 24. That means it is 10 units higher than the expected. The corrected bicarbonate 34 is higher than the normal value of 24. If the bicarbonate is higher, there is excess alkali in the body, which means metabolic alkalosis. If the corrected bicarbonate is lower than 24, that means alkali is reduced. That means there is an associated metabolic acidosis. Already we are seeing here agma. So the associated acidosis will be non-anion gap acidosis. Then of course you do again the urine anion gap and find out what is the cause of the nagma. Okay? This is how you go. When you have nagma, you don't have to do the osmolar gap. When you have agma, you do need to do the osmolar gap. Why? We have got the mud piles. Some of them increase the osmolar gap, some of them will not increase the osmolar gap. There is a table when both are increased, only one is increased. And to use the table, we require the osmolar gap also, osmolarity gap. Now, there is one more step. We have only looked at the bicarbonate. How about the PCO2? To know that whether there is any respiratory mixed disorder, we require the PCO2 to be known. The Winter's formula for the expected PCO2 is equal to bicarbonate multiplied by 1.5 plus 8 plus minus 2. Okay. Bicarbonate here is 14 in this particular example. 14 plus 1.5 is equal to 21 plus 8 is equal to 29 plus minus 2. 27 minimum I should get. But my bicarbonate is how much? My carbon dioxide is how much? I must get 27. What is the given carbon dioxide? Yeah. It's not written here, but you compare. Oh, it's given 27. Carbon dioxide is 27. My expected also is 27. So naturally, there is no associated respiratory disorder. Okay. All this boils down to normal bicarbonate is 24 plus multiplied by 12 is multiplied by 1.5 is equal to 36 plus 8, 44 plus minus 2 is equal to 42. The expected PC is 40 in normal value. So 40 versus 42 is equal to 1:1. This is what we were earlier calculating. Whenever there is metabolic acidosis, the compensation is equal to 1:1. Same thing. You can use the formula to be more accurate, or you can write 1:1 also. You can see. Okay. So let us use the 1:1 situation. So for every drop in the bicarbonate, so the drop here is 10 units. We expect the drop in the carbon dioxide to be 10 units. So normal is 40 minus 10 is equal to 27, plus minus 2 points are allowed 27. The 40 minus 10 is equal to 30. Here we have 27. There is no associated respiratory problem. So what if the expected carbon dioxide doesn't match that? Then we will see that. If the given PCO2 is more than the PCO2, expected PCO2, given PCO2 here is 27, expected also 27, there is no other disorder. If it is more than the expected PCO2, that means carbon dioxide is retained by the lungs, there is mixed acid-base disorder, respiratory acidosis is added. If the carbon dioxide is less than the expected, that means carbon dioxide is washed out by the lungs, there is a respiratory alkalosis. Okay. Let us do an example and see how this looks like. Then you will understand this very well. Okay. Okay. Now, 7.15, 40, 85, 15. And this is 140, and then 98 and 15. Okay. Now, one of you open. Deepa?
Yes, sir.
pH is?
7.15, sir. Acidosis.
Right, acidosis first. Next question is by carbon dioxide. Carbon dioxide is not changed, so it is normal. So we don't know anything from that. Then we go to the bicarb. Bicarb is lower.
Yes, sir.
Lower means met acidosis. Both are on the same side. So met acidosis. No question of acute or chronic here. So it is met acidosis. The question is it agma or nagma?
Nagma.
Okay.
Yes, sir.
For that, what I require?
Anion gaps.
Minus 98
plus.
Okay. That is equal to 140 minus 113, right?
Yes, sir.
Equal to 27. 27 is higher. So what is my delta Ag? 27 minus normal 12, which is equal to 15. My delta Ag is equal to 15. So I am in a situation of anion gap metabolic acidosis. My next step would be to do osmolar gap. To know whether both are raised or only one is raised. Like that. This table will be like that. This is anion gap, this is osmolar gap. There are conditions associated with that. One, this is normal, this is raised, this is normal, both are raised. So for that table to go for differential diagnosis, I require. But my question is not to have a differential diagnosis of agma here. I wanted to know whether there is a mixed disorder or not. For that reason, I will keep the differential diagnosis for a while other side, and then I would like to see what is the bicarbonate concentration, bicarbonate compensation, whether it is appropriate or not. So I added this 15 to the observed bicarbonate 15. Observed bicarbonate 15, expected change in the anion is 15. So total will be, the calculated will be 30. This 30 is more than 24 or less than 24? It is much more than 24. How? So if it is more, there is excess bicarbonate, which means there is an associated metabolic alkalosis. Okay. So there is the diagnosis here is metabolic acidosis plus associated met alkalosis. How did I get it? I worked out the anion gap, added the delta anion gap to the observed bicarbonate. Observed bicarbonate or given bicarbonate is 15. This is 15, so it is 30. Normally expect this answer to be 24. It is deviating from the expected 24. That means the bicarbonate is somehow pulled up by some other reason. That some other reason is metabolic alkalosis. Okay. And then is there any respiratory disorder associated with that? How do I know that? So the delta PCO2 is equal to bicarbonate times 1.5 plus 8, the whole thing plus minus 2. So bicarbonate is 15,
Minus 2.
15 into 1.5 is equal to 22.5. Okay, plus 8 is equal to 30.5 plus 2 is equal to, it could be upper 32, lower 28. It should be anywhere between 28 and 32. What is that? The PCO2. What is my PCO2? 40.
40, sir.
That means it is much away, higher. That means carbon dioxide is retained. Means what? There is an associated respiratory acidosis.
Okay.
Okay? So this is a condition where there is an anion gap metabolic acidosis, there is a metabolic alkalosis, there is an addition respiratory acidosis. That is how you work out the compensation. I mean, the compensation is appropriate or not, we have looked at and we found out this is a case of mixed acid base disorder. Okay?
Okay,
One
sir.
second, huh? Hello? Let's take another example and see. So we will use the page number, next page, we can say page 2. So wherein we will take another disorder where there is a combination. So 7.38, 39, 90, 23. These numbers are 140, 80 and 23. 80 or 87, okay, 80. In the previous example, we forgot to calculate the consistency. So let us look at the consistency in the previous example. Consistency is equal to H ion is equal to PCO2 40 divided by bicarbonate 15 into 24. So can somebody do that? 40 into 24 divided by 15. 40 into 24 divided by 15 is equal to 64. It has come to 64. So 80 minus 64 is equal to 16, 7.16, my pH is 7.15. So internal consistency has to be checked. That is true. That is okay for that particular exercise. Let us check the internal consistency here first. Internal consistency is 24 multiplied by 39 divided by 23. So it's almost, 1. So it's 39, let us say. 39, slightly more than 39, because this is lower number, 40. 7.4, 1 it comes. 7.3. Actually, we can do 24 into 39 by 23. 24 into 39 divided by 23. That's equal to 41. It has come 41. 41 means the pH will be 7.39. 7.3. Tally. Now, the next first question is the pH acidic? Some other person can open. Deepa has answered. Let us see, some other person will work it out.
Hello, sir.
What is your name? Rajaram.
Yes.
Fine. What is the pH like?
Normal.
No, 7.4. Normal, you given an acid-base mixed disorder case, 7.4 is the normal range. So it is lower, isn't it? When the pH is lower, immediate question is about the carbon dioxide, which is not telling much. So 40 and 39. And next question is bicarbonate. But there is a marginal reduction in the bicarbonate. And this also is reduced one unit. All of them going down?
Yes, sir.
Metabolic acidosis. But we are not seeing a very gross change here as well as here. That means there could be some associated disorder which is keeping them in balance. Possibly When you see a sort of pH around 3.8 and some disturbances in the other things, you can suspect a mixed disorder. The next question is, if it is acidosis, next question is N or non-gap or gap. Non-gap or gap. How do I know that? By going here. 140 minus
140 minus 87 plus 23, sir.
which is equal to 140
36.
minus
110.
110.
36
30. Is it gap or non-gap?
gaps.
Definitely gap. So we are dealing with gap acidosis. When you have gap acidosis, you require osmotic gap, which we are not doing because our focus here is not in the differential diagnosis, but in the workup. With this gap acidosis, is there a combined disorder? How do I know that? Now, what is the delta gap? Delta anion gap is equal to 30 minus 12.
10. 26.
12, you take 12, and that comes to 18. This 18 units of anions are there. So the bicarbonate is only 23. Suppose these 18 units anions are not there, what would be the bicarbonate? That means 23 plus 18, 41. 41 is much higher. 41 is much higher than 24. 24 is normal. My bicarbonate has shot up somewhere. There is a severe metabolic alkalosis because there is excess retention of alkali. It is a metabolic alkalosis. So there is a metabolic acidosis and also metabolic alkalosis. For example, patient had got diabetic ketoacidosis, he has got anagma, anion gap acidosis, severe vomiting. So he had got metabolic alkalosis also. Is there a respiratory disorder associated with that? That we need to know. So how do I do that? So I do that the delta PCO2 is equal to bicarbonate multiplied by 1.5 plus 8, the whole combined plus minus 2. Bicarbonate, given bicarbonate is 15, I think. 15.
23.
Sorry. 23, sorry. Previous sum it was 15. 23 multiplied by 1.5 is equal to 11.5 we have to add, that is 34.5. So the half of this is 11.5. So 34.5 plus 8 is equal to 42.5. What is my carbon dioxide given? 39, I think.
39.
42.5 minus 2,
39.
40.5. Plus 2 will be 44.5. So it can be anywhere between these two values. My associated carbon dioxide is 39. Even after adjusting minus 2, still it is on the lower side. So this would be, there is a mild amount of carbon dioxide washout. So respiratory alkalosis. But nonetheless, it is very mild. So we did not have much of that. So in this particular disorder, as we have seen previously, he has got anion gap metabolic acidosis and he has got severe metabolic alkalosis. And there is a mild respiratory alkalosis because the carbon dioxide is lower than expected. The carbon dioxide is higher, it means as a carbon dioxide is retained, which is respiratory acidosis. That's how you work out. So let us go back to the sharing of the presentation. So can you see my presentation back? Yes or no?
Yes, sir.
Yeah, okay. We'll go ahead with the presentation. Okay. So in general, if you are dealing with metabolic abnormalities, not respiratory, if you are excluded and looking at metabolic abnormality, this table will help you. Calculate the non-anion, calculate the anion gap. Sodium minus bicarbonate was chloride, you know that. Is it less than 12 or is it more than 12? First question you put like that. This is a very vague and simpler way of looking at it, rather than doing all those sums. So this is a simple way of eyeing the data. Is it more or less? If it is more, we are in the agma, and if it is less, we are in the maybe in the nagma. If it is less than 12 and the bicarbonate is around 24, then it is the bicarbonate is normal, anion gap is normal. This is the normal individual. You can bring it down to 24 to 26, not 28. because plus minus 2 only is allowed. So minus 22 to 22 to 26 bicarbonate. Anion gap is normal. In normal individual also anion gap will be less than 12. Bicarbonate is normal, and I am not dealing with any metabolic disorder. The other way around. Anion gap is less than 12, but bicarbonate is much pulled down. That means commensurate with the anion gap, there is an acidosis also. Alkali is lower. That means we have pure Nagma. Pure Nagma. The other way around. If you have anion gap less than 12, but the bicarbonate is pulled up due to some other reason, there is an associated metabolic alkalosis. Okay, I'm simplifying it for you. First, look at the anion. If you are thinking of metabolic disorder, not respiratory. Respiratory is a separate story. Today's discussion is metabolic disorder. That already respiratory acidosis, alkalosis, we completed. Now, if it is a pure metabolic disorder, then what is the anion gap? If the anion gap is less than 12, three possibilities are there. One, look at the bicarbonate. Bicarbonate is in the normal range. Anion gap is less than 12. Look at the pH. pH is also normal. Then probably this fellow does not have any other disorder. Normal. If the anion gap is less than 12, then look at the bicarbonate. The bicarbonate is lower. That means there is a metabolic acidosis of what type? Non-anion gap type, pure. In such case, the pH also will be lower. And the other scenario is anion gap is reduced, pH is normal or just like borderline, but the bicarbonate is very high, means that you have got associated factor which is pulling the bicarbonate up. What pulls the bicarbonate up in the metabolic thing? It is the metabolic alkalosis. That is why the pH is around 7.39 or 38 like that. It's not as expected lower because this combined disorder is pulling it up. So go to the other side. So we are dealing with an anion gap metabolic acidosis. Immediately look at the delta gap. Delta gap is elevated. And then bicarbonate. You add that bicarbonate to the present gap, or without adding also, straight away the given bicarbonate you subtract from 24. There is a reduction in the bicarbonate. Three scenarios. This difference that you see is the same as the bicarbonate difference. That is, the anion gap is same as the delta bicarbonate. In which case you have a pure AGMA. There is no other associated alkalosis or acidosis. If on the other hand, the bicarbonate is more than the anion gap, there is an associated metabolic alkalosis because bicarbonate is alkali. If on the other hand, bicarbonate is lower than the anion gap, then there is an anion gap acidosis associated non-anion gap acidosis. This chart also I am giving you in the PDF. You observe this carefully. This you can very clearly use it for the advantage. So this chart I have shown you earlier. If both the delta gap and the delta anion gap and the delta osmolarity gap are increased, this is called the double gap or double delta. You have the acronym is MPEG. MPEG is the file you use now. MPEG file, just like JPEG, you use MPEG. M is methanol, E is ethanol, and then EG is ethylene glycol, and then P is again propylene glycol. Okay, so MPEG is the acronym here. If only anion gap is there, osmotic gap is not there, it is either salicylate or acetaminophen. In salicylate, you will have associated alkalosis. In acetaminophen, you will have associated metabolic acidosis. So respiratory acidosis. Now, if the anion gap is normal, but the delta gap is normal and the osmotic gap is higher, then you are dealing with isopropyl alcohol. Okay. If both the anion gap and these things are raised, we are here. Other than the poisonings, you have to no history of any poison ingestion. Then you have to consider internal metabolic causes like diabetes, lactic acidosis, and CKD. So if there is an anion gap, delta gap, if there is an osmolar gap, both are raised. Either I am dealing with poison or I am dealing with a metabolic disorder. Look at the history. History says ingestion of substance. What substance? Methanol, ethanol, ethylene glycol, propylene glycol. If there is no history of ingestion, I am with a metabolic disorder. What is my sugar levels like? What are my ketones? Is there lactic acidosis? Is there a CKD? That's very simple. Both are elevated. It's a double gap. Whereas when you have only anion gap and no osmotic gap, two conditions are possible. Anion gap metabolic acidosis, salicylate and acetaminophen. One is associated with respiratory alkalosis, which is a salicylate. This is associated with respiratory acidosis, which is acetaminophen. We have seen example also about that. Now, if my anion delta gap is normal, but the osmotic gap alone is then it is an isolated alcohol, isopropyl alcohol. Isolated isopropyl alcohol. This is how you work out the differential diagnosis using the osmotic gap. Now I am summarizing. Anion gap, you worked out the moment you find out metabolic acidosis, you did the anion gap is normal, I am dealing with non-anion gap metabolic acidosis. Here if it is higher, I am dealing with AGMA. If it is AGMA, what is the osmolar gap? It is increased, ethylene glycol, methanol, like that. If it is normal, uremia, lactate, ketoacidosis, salicylates. Whereas you go this side, look at are there any GI fluid losses? If yes, the NAGMA is because of the GI cause, GUT, gut negative, ileostomy, diarrhea, enteric fistula, pancreatic fistula. If there is no GI fluid loss, look at the pH of the urine. Is it very acidic? Is the urine being acidified well or not? This is acidic urine. This is relatively less acidic urine. If it is not acidified well, that is distal RTA. If it is acidified well, what is my potassium? If the potassium is higher, it is type 4 RTA. If potassium is lower, it is type 2 RTA. Type 3 RTA doesn't exist nowadays. So we have type 1, type 2 and type 4. This differentiation you will come to know in the subsequent classes. Now, this RTA by definition will throw a NAGMA and it is not associated with a GI loss. Okay, and then look at the pH. Is the urine enough acid or not that much acidic? If the urine is enough acidic, then look at potassium. If the potassium is low, it is type 2. Potassium is high, it is type 4. If the urine is acidic compared to what now I mean less than 5.5, then this is distal renal tubular acidosis. On the other hand, if none of these things are there, but the history of GI fluid loss, one of these causes is the cause of this NAGMA. Here we have hauled up or used cause is the acronym. For this side, the acronym you know, mud pies. Okay. So we have discussed enough about the metabolic acidosis and the combinations. Now I'll tell you about metabolic alkalosis, which is a relatively isolated disorder usually and is not combined usually. When you see metabolic acidosis, you don't have to do osmolar gap, urine gap, you don't have to do the compensations and all that. Straight away look for, if it is a simple metabolic alkalosis, look for the differential diagnosis. How do I do that? So, if you have metabolic alkalosis, now finished respiratory acidosis, respiratory alkalosis, and acute and chronic there, and finished metabolic acidosis, again AGMA and the combined disorders. Now we are dealing with metabolic alkalosis. In general, remember the following questions as a clinician. Number 1, what is the volume status? Is it hypovolemia or normovolemia or hypervolemia? And then second thing is, what is the potassium like? Third thing is, what is the BP like? Fourth thing is there a sort of renin like? Renin is not a clinical thing you do later on. Hypertension, potassium, volume, and also urine chloride. And then dehydration, volume lower, volume non-low, and associated diuretic use. Diuretic and dehydration. And associated endocrine disorder. If you are seeing metabolic acidosis, you should put these following questions. Is my patient normovolemic, hypovolemic or hypervolemic. Second thing is what is potassium value. What do you expect the potassium in alkalosis? It will be lower because, in acidosis, the potassium is high, in alkalosis, it is low. That we know. Then, is the patient normotensive or hypertensive? And what is the renin level? Is it high renin or normal renin? What is urine chloride? It is less than the particular value, less than 20 or more than 20. Is there an associated GI loss like diarrhea or vomiting, nasogastric suction and things like that? And is there associated dehydration and diuretic use? These are the clinical questions you need to put. So if you want, I will write it here for you. You can copy them. So what is the first question? Volume status. Volume status is the first question. Second thing is the hypertension. Okay. Third thing is potassium, serum potassium. Fourth thing is urine chloride. Fifth thing is GI disorder. History of GI disorder, either vomiting or diarrhea. Sixth thing is diuretic use. Diuretic use. And seventh thing is dehydrating, any dehydration due to any other cause. And eighth is endocrinal disorder, underlying Cushing's or Addison's or pheochromosis, the primary hyperaldosteronism, or even diabetes for that matter. Okay? So these are the questions you need to answer. Clinically, what is the volume status? What is the blood pressure? What is the potassium? Is it low or normal? And what is the chloride like? Urine chloride. GI disorders associated vomiting or diarrhea or nasogastric suction or anything. And is there any use of diuretics? Is there dehydration? Is there endocrine? The ninth and important question is there exogenous alkali administration? Like excessive antacids or milk alkali syndrome, or by IV somebody has pushed an alkaline solution like bicarbonate being given, unlikely, isn't it? Exogenous alkali administration, not a common cause. The common cause is a volume disturbance and GI disorders, use of diuretics, dehydration, maybe underlying endocrine disorders. So remember these 9-10 questions when you are dealing with a case of metabolic alkalosis. Okay. Now I changed the share. Hope you are able to see the share. Okay. If you are not seeing, you answer. If you are seeing, I can presume that you are seeing. Now what did I do? Then went into the history, of course, the clinical parameters, and then excluded hypercalcemia, milk alkali, important conditions, alkali administration. If these are not cystic fibrosis, not very common, refeeding alkalosis, beta-lactam antibiotics are also causes. If these are not there, none of these are there, then immediately look at the urine chloride. There are two possibilities. One is urine chloride low and urine chloride more than 20. Why urine chloride is important? This is to know whether the patient is salt responsive alkalosis or salt resistant alkalosis. It is called salt responsive and salt resistant, or saline responsive metabolic alkalosis, saline unresponsive metabolic alkalosis. The moment somebody comes with some into the, what do you do? Immediately you connect NS on powder, NS petandi, pedest. NS sodium chloride. You become maybe normal, because if it's simple metabolic acidosis, you put him NS, most of the conditions are saline responsive. So he gets up and becomes normal. But without your knowledge, you have treated him correctly. On the other hand, if the metabolic alkalosis is there, which is NS resistant, giving sodium chloride will be dangerous. For that reason, we have to look at that. Okay. So how do I know that? Immediately look for the 6 or 8 or 9 clinical questions, and none of these things are there, like the listed historical features here. Then look at urine chloride. Differential diagnosis goes by this channel. Urine chloride less than 20. I told you diuretic therapy is important. Gastric loss of hydrochloric acid. HIN is lost. That is why alkalosis acid is lost. So alkali excess, and along with that chloride also is lost. That means either by the nasogastric aspiration or by vomiting, the acid and the chloride are taken away. So there is a metabolic alkalosis. So responding to chloride. And these are little rarer causes. Okay. Now, what if my chloride is normal? Why here in this case the chloride will be, urine chloride will be low? Already he is having hypochloremia in the blood. It does not want to lose chloride. Kidney conserves chloride. Kidney doesn't excrete chloride because there is a deficiency of chloride in the body, and it is not available to be appearing in the urine. And so you have a low urine chloride, means that will be salt response. Then if the urine chloride is higher, then my next question is there hypertension? Okay, if there is no hypertension, diuretic therapy, Barter's, rarer syndrome, Gittleman, hypokalemia, and hypomagnesemia. The hypertension is there, do potassium. If the potassium is lower, then you are dealing with, and magnesium and potassium go hand in hand. Okay, so the potassium is normal, then you are dealing with the other thing. The potassium is lower and magnesium is lower. So you did a urine chloride, then also ask for urine potassium, look at the hypertension, not hypertensive. These are the conditions. If hypertensive, then look at the serum renin levels. Is the hypertension secondary to high renin, or it is due to a sort of any other thing which is increasing the blood pressure due to non-renin mechanisms? Non-renin mechanism is aldosterone. So there are two things which can increase the blood pressure, either the renin or the mineralocorticoid. Is it renin or non-renin? How do we know that? Look at the serum renin. The serum level renin is high, ongoing diuretic therapy, secondarily renin is stimulated, or there is a renal artery stenosis, or a renin secreting tumor, or it is malignant hypertension. How did we come here? First we excluded all those by history, then looked at the urine sodium, urine chloride. Urine chloride is higher, sufficiently higher to say that the chloride excretion is unaffected, and there is chloride enough in the body. Then the question is there hypertension? There is no hypertension, certain causes excluded. There is hypertension. Is it high renin hypertension or due to something else? If it is high renin, is it a continuation of diuretic therapy stimulating the renin, or there is a renal artery stenosis with juxtaglomerular apparatus secreting more renin because of the renal artery stenosis, or there is an extrarenal renin secreting tumor, or it is a malignant hypertension. Okay, if the renin activity is lower, that means renin is not the cause. There is some other sodium retention occurring due to either aldosterone or non-aldosterone mechanism of the sodium retention, and then the alkalosis. So, if the hypertension is not because of aldosterone, but due to something else, what is that something else? Without aldosterone elevated, that means the glucocorticoid elevation causing the hypertension. Corticosteroid outside use, or there is a deficiency of 17-hydroxylase. I very rarely, lycorhizin, Liddle syndrome. Very simple. Then if the aldosterone levels are high, I know the hypertension that I got in this patient associated with metabolic alkalosis is because of aldosterone excess. How can aldosterone be excess? There is a primary adrenal adenoma. That is, this adenoma is commonest cause of hyperaldosteronism is adrenal adenoma, or benign adrenal bilateral adrenal hyperplasia, or aldosterone synthetase hyperactivity. There is an enzyme called aldosterone synthetase, and genetically that becomes hyperactive. These are the three important causes of hyperaldosteronism. Either adrenal adenoma or adrenal hyperplasia, which is the next important cause, bilateral adrenal hyperplasia, BAH, or there is an aldosterone synthetase hyperactivity. This is how I do a differential diagnosis of a case of metabolic alk. Today, take this question 7.24. Look at the clinical history also. You can see the clinical history also. You are not answering the questions. Whatever I have given last week, that also you did not answer. 67-year-old male, status, gastrectomy, returns 12 days later with nausea and decreased mental status. Temperature 39, BP 80/50, hypovolemic, then pulse rate is 130, tachycardia, drowsy, minimally responsive, lungs clear, heart tachycardia, respiratory rate is normal, there is no hyperventilation, there is no hypoventilation, that's important for us, and there is no pleural rub or anything. Abdomen diffusely tender, externally there is no edema of the extremities. EXT is extremity edema. There is no heart failure or retention of water. Now the values are, take the values 7.24, 24, 95 and 12.
Sir, it's acidosis.
Now leave it on
The
that.
parameters
But
are
how about this? How about this? Creatinine of 5.4.
Yes, sir.
Urea of 86 tells me there is an acute or chronic renal involvement.
Okay, sir.
Okay, that is the striking thing. Of course, there is acidosis. Acidosis and renal involvement could be what type of involvement is that? Metabolic acidosis.
Yes, sir.
And then that is supported by these two.
Bicarbonate and
Both are
PCO.
going down. This is also done. Everything is down, metabolic acidosis. Now, how about the consistency? 24 divided by 12 into 24. Very easy calculation.
Yes, sir.
48. 48 means it is 22.
32, sir. 7.
32. So data doesn't appear to be consistent. Is it correct? 24 and 12. So 28, 48. So data consistency not verified. What I do? What if I don't get a data consistent? You still go ahead with the calculation with the given data and then give a remark that we require to redo the ABG in view of the inconsistency of the data. What are the causes of inconsistency of the data? What are the causes? One, while drawing the sample, there is a mixture of the air. Two, the venous and the arterial samples are not drawn at the same time. Okay. Three, there is a delay in the transportation of specimen to the lab. Okay, there could be other factors also. Now, let us assume that the data is consistent. When the data will be consistent? Okay, well, let's not do that. Let's assume, of course, we have found out a problem that we will address it. Now, what sort of metabolic disorder, acute metabolic acidosis? Metabolic acidosis. Is it agma or nagma? Next question. Chloride is much lower. Chloride is not compensated. This normochloremic or rather even hypochloremic. It must be anion gap acidosis because the total is 107 minus 1 for 132 here. We have to subtract from 132, which is still 25. 25 is higher. Okay. So 25 is higher. How many units? 13 units higher. So I add that 13 to my bicarbonate. That is 25. My expected is 24. There is no associated metabolic disorder because 25 and 24 are the same. Okay. Is there any respiratory thing associated? Then my delta PCO2 is equal to 1.5 times the bicarbonate plus 8 plus minus 2. Bicarbonate is 12 multiplied by 1.5 is 18. 18 plus 8 is 26. 26 plus minus 2 is 24. 24 is my PCO2. So there is no associated respiratory disorder. Isn't it? But for the fact that the data is not consistent, this patient appears to be having anion gap metabolic acidosis due to renal failure. Okay, what is the history like? He had gastrectomy, and after that he came back with renal failure. Okay, so that is the cause here, because this is how you work out. Okay, anyway, this I have worked out. I'll give you one more example. Case 2, you take this. Take this and work it out.